think we'll get started. Good afternoon and welcome to today's webinar, Every Step Counts, Stroke from a Rehabilitation Perspective. Thank you for joining us this afternoon. My name is Barbara Chabner and I'm the Director of Education and Outreach at the Brain Injury Alliance of New Jersey. For those of you who are unfamiliar with the Alliance, we are a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been impacted by brain injury. I would like to note that we have a tab on our website, BIANJ.org, where you can view and register for all of our upcoming webinars over the next few months. Our next webinar will be held on June 12th on TBI evaluation and management. We are also hosting our free Family Fest on June 2nd and 9th, as you can see on the slide. And this is an event for families who have been impacted by brain injury, for people with brain injury and their families. It's a fun, recreational, social, educational day. And if you would like more information, you can find it on our website. So just a few housekeeping notes before we begin the presentation. Attendees' microphones have been muted. If you have any questions during today's webinar, please type them in the Q&A box. We will get to as many questions as possible at the end of the presentation. The webinar is being recorded and will be available for viewing on the BIANJ website. You will also receive an email the next day or two following the webinar that will have the recording of the webinar. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, so you are encouraged to complete the survey. You must complete the survey in order to receive a certificate of attendance. Once you complete the survey, you will automatically receive your certificate of attendance via email. Please check your spam folder if you don't see your certificate of attendance, because sometimes it ends up in the spam folder. So our presenter for today is Jennifer Vasilik. Jennifer Vasilik is a neurologic physical therapist practicing in the outpatient setting at physical therapy at St. Luke's in Phillipsburg, New Jersey. She attended DeSales University in Center Valley, Pennsylvania, where she earned a bachelor's degree in health science with minors in psychology and sport and exercise physiology. Jennifer continued at DeSales to complete her doctorate of physical therapy degree. She treats a variety of neurologic diagnoses with special interest in stroke, brain injury, Parkinson's disease, and vestibular disorders. She is a certified stroke rehabilitation specialist and a LSVT BIG certified clinician for Parkinson's treatment. Jennifer believes in identifying goals important to each individual to guide their treatment as they recover from or cope with neurologic disease. I'm pleased to welcome Jennifer today.
Hi, everyone, and welcome. As Barbara mentioned, my name is Jen Vasilik, and I am a physical therapist at Physical Therapy at St. Luke's in Phillipsburg, New Jersey. So we're going to be talking about stroke rehab today, and it's a good timing as May is Stroke Awareness Month. So just a little bit about me. Like Barbara mentioned, I went to DeSales University for undergrad and for physical therapy school, and now I'm an outpatient neurologic physical therapist. I have special interest in treating stroke and Parkinson's disease as well as vestibular dysfunction, but I do enjoy seeing a wide variety of diagnoses. So here's a summary of our time together today. We are going to look at the different types of stroke, risk factors for stroke, and what happens after someone experiences a stroke. I'm not sure exactly who's making up our audience today, but I would imagine we likely have some people who may have had a stroke or have loved ones who have had strokes. And there's probably some people here who work with individuals who have had strokes. So I hope that no matter who you are or what brings you here today, that you might take away even one little nugget of information that's new, or that you might see in a new light. And just as a little disclaimer, the information presented today is intended to be general information and should not be taken as medical advice. Please speak to your medical team for an individualized approach to your health and wellness. All right, so let's get into things a little bit. So a stroke is disruption of blood flow to the brain. There are two main categories of strokes, ischemic and hemorrhagic. Ischemic strokes occur due to a clot in an artery, which prevents the flow of blood and thereby oxygen to the brain. And hemorrhagic strokes occur due to the rupture of a blood vessel with resultant bleeding into or around brain tissue. When we have this sudden significant impact on blood flow to the brain, we will see that the areas of the brain that are supplied by the impacted blood vessels are not able to function as they should. So each of the arteries in the brain is responsible for supplying various parts of the brain, which in turn control virtually all of our body's functions. Think back to high school when the catchphrase was the mitochondria is the powerhouse of the cell. Well, the brain is essentially the powerhouse of the body, this like great controller. And if it's not getting the nutrients that it needs via blood supply, then there's going to be consequences. After a stroke, there's typically an area of cell death within the brain, and then an area around it called a penumbra, which has been impacted by decreased blood flow, but it does have the potential to survive. And we'll get a little bit more into that later. Stroke is a very highly studied condition, and for good reason. As we'll see in the next few slides, there are millions of people affected by and billions of dollars spent on stroke each year. And these numbers just keep on growing. Currently, stroke is the number 5 cause of death in the United States, and it's the leading cause of disability. 9.4 million Americans report at least one stroke in their history, and another 3.4 million are expected by the year 2030. The lifetime risk of having a stroke is 1 in 5 for females and 1 in 6 for males, and we'll get into that a little bit more later. And on average, someone dies from stroke every 3 minutes and 14 seconds. And this next one is really important. Up to 80% of strokes are preventable. As you can see by the numbers on the screen, stroke is very, very expensive, and the costs continue to rise. Direct costs refer to the actual medical care that is needed after a stroke, and then indirect costs include things that are impacted after a stroke, such as employment and inability to work. All right, so a well-known acronym regarding stroke symptoms is FAST, or face, arm, speech, and time. This refers to common symptoms which present at the onset of a stroke: facial droop, arm weakness, speech difficulty, and time to call for help. As we'll discuss in a bit, the time it takes from symptom onset to receiving medical care is so critical to achieving better outcomes. Some other common symptoms include those that you can see on the screen, including numbness, increased confusion, trouble speaking, vision changes, especially double vision, trouble walking, dizziness, and coordination or balance issues, and severe headache. I highly encourage anyone who does experience such symptoms to seek medical care immediately. So we just talked about immediate signs and symptoms of stroke, but what about what happens afterwards? What residual effects might we see? Well, it depends on where the stroke occurred. So the artery affected and the location within the artery will determine which area of the brain is impacted. And that in turn will influence what deficits we may see. And then depending on where the stroke occurred, we may see deficits on the opposite side of the body versus on the same side. So we're not going to get into the specifics of the nitty-gritty of brain structure and function today, but I do encourage anyone who is interested to take a deeper dive into this area. So we may see deficits in strength, sensation, proprioception, which is awareness in space, muscle tone, cognition, vision, speech, swallowing, and more. Virtually every function that the brain controls, which is really everything that we do, can be impacted depending on where the stroke has occurred. All right, so now I'll look at risk factors. Risk factors for stroke can be divided into 2 categories: things you can change, modifiable, and things you cannot, or non-modifiable. Now, this is where my little disclaimer comes in. If anything we're about to talk about strikes a chord in your mind, please speak to your medical providers prior to making changes in your lives. Okay. Taking a look at these modifiable risk factors, I want you to consider the little tidbit in the green box. 87% of strokes can be attributed to modifiable risk factors. It is so important to consider how our habits related to our health can have a big impact. High blood pressure, diabetes, high cholesterol, atrial fibrillation, sleep apnea, carotid artery disease, peripheral artery disease. They're all some big words and they may seem like they exist in silos, but those conditions can be strongly related to some of the other things we see on the screen: smoking, diet, physical activity. These are direct habits that we can address to lower our risk of stroke. Diet can be an overwhelming topic. I was actually just talking to one of my coworkers about this recently. It seems like there's so much information out there: high protein, low fat, no carbs, intermittent fasting, keto. The number of different terms and diets and tips and tricks that I've heard is overwhelming. Even as someone with a lot of education in healthcare, I do encourage anyone with concern in this area to consult a nutritionist or a dietitian for individualized guidance for your specific needs. So, for physical activity, current guidelines from the American Heart Association recommend 150 minutes of moderate intensity exercise per week, or 75 minutes per week of vigorous intensity exercise. However, the amount of people who actually meet these recommendations is pretty low. I believe I saw a statistic recently that less than 30% of adults meet that recommendation. Of course, before starting an exercise program, I would recommend talking to your doctor or even seeing a physical therapist or other exercise professional for help with getting started. Even considering a few small ways we can address the big picture of our health through our habits can make an impact. Like I said on the very first slide, every step counts. All right, so now for the other side of things. Here we see risk factors for stroke, which we cannot control. People who are older are more likely to experience a stroke, and family history of stroke may also mean that someone is more likely to experience one. Race can have an impact as well, and stroke is more likely in women. That's thought it to be at least in part to the fact that women tend to live longer than men. There's also a higher risk of stroke seen with pregnancy, preeclampsia, gestational diabetes, and the use of oral contraceptives. And having a history of a prior stroke, TIA, or heart attack also increases your risk. If someone has a history of a TIA, then they're 10 times more likely to have a stroke in the future. Okay, so each of the things we've talked about in the past few slides is related to the risk of having a stroke, but they also come into play with stroke recovery. Higher levels of physical activity are associated with lower stroke severity at hospital admission, as well as better functional outcomes and more independence 3 months post-stroke. And inactivity, on the flip side, is associated with poorer outcomes and greater dependence following a stroke. Okay, so in the event someone has a stroke, the most important thing to do is to get to a hospital as quickly as possible. There you would be evaluated by medical professionals and likely have imaging to see what's going on inside your head. There's a medication that may be used to address ischemic strokes. It's called tissue plasminogen activator, or TPA, which is sometimes called a clot buster. This medication typically needs to be administered within about 4.5 hours of symptom onset. So that's where that T in that FAST acronym comes into play for time. Other potential interventions for ischemic stroke include mechanical thrombectomy, or going in and removing the clot from the impacted blood vessel to restore the flow of blood to brain tissue. Hemorrhagic stroke may be treated by surgical clipping of an aneurysm. This isn't an all-exhaustive list of medical treatments, and honestly, that's not really my wheelhouse per se. I more so come into play afterwards. There are others out there, other treatments, but this is kind of what I found to be the most common through my research. So after experiencing a stroke and presenting to the hospital, usually through the emergency room, one will likely be admitted to acute care. And here the focus is typically on medical stabilization and figuring out what happens next. Now, before we get into that, I do want to touch on the fact that the flowchart on the screen does not take death into account. And unfortunately, death is a potential outcome following an event like this. And it could occur pretty much anywhere along this timeline that you see on the screen. But as our focus today is on rehabilitation, we're going to mostly focus on what happens with people who are survivors of stroke. So, one of the jobs of those who work in acute care is determining the next level of care for a patient. This may include going home, acute inpatient rehabilitation, skilled nursing facility, long term acute care. So, long term acute care is typically an option for people who have ongoing acute needs which require continuous monitoring. Skilled nursing facilities provide rehab for individuals who are not ready to go home. And acute inpatient rehabilitation may also be an option for people who aren't ready to go home and can tolerate intensive therapy, typically about 3 hours per day. Some people may be ready to go directly home after the hospital. And in that case, they may require home health, outpatient therapy, or have no skilled therapy needs. And of course, nothing's ever simple, and some people may require multiple settings, such as acute care, and then acute rehab, and then home health, and then outpatient therapy, or other variations. Each person is different, and therefore their needs and situations are different. So it's critical to have skilled individuals to help guide their recovery journeys. Okay, so here's a look at the rehab team that typically works with individuals after a stroke. Now, please note this is not an all-inclusive list, and if I'm missing anyone from this list, I apologize. Everyone brings something different and important to the table, and our patients are better for it. The most important member of the rehab team, in my opinion, is the patient. Being involved in your own care and driving the decision-making is really important. So here we have a look at what specifically PTs, OTs, and speech language pathologists do. Each one's important to the rehab team and brings different skills to the table, but there's also some overlap. I don't really want to get on a soapbox here, but it's a sign of a good rehab program when all the disciplines work together to achieve a multidisciplinary approach. Pretty much every day, I'm talking to OTs and SLPs to determine ways that I can improve the care I'm providing to patients. For example, maybe in speech therapy one day, a patient is working on naming items and categories. Then I can use that as a dual task in physical therapy combined with a mobility task to promote carryover between disciplines and additional practice and further challenge the patient. Human beings are complex and our lives can't be isolated into silos, and therefore rehab shouldn't be either. So we've talked a lot about therapy and rehab. So what does therapy look like? Well, the specifics will vary between settings. A PT evaluation in the ICU is going to look a lot different than a PT evaluation in outpatient therapy. But the basics are pretty much the same. In an evaluation, we're going to be looking at identifying patient-specific goals, things that are important to the individual. We'll examine the impairments and the barriers to meeting those goals, and then figure out a plan to reach them. In follow-up sessions, we'll use the combination of specific exercises and education to address those impairments. Education can be just as important as exercise itself. Information about what we're doing and why, ways to improve safety, and more. And there might be a home exercise program too to reinforce gains made in PT, or OT or speech. We know that practice helps with skill acquisition, and continually practicing will only serve to help in the long run. And then we'll perform reassessments to determine if we're making progress toward our goals, and if not, trying to figure out what needs to change to make that happen. Okay. Neuroplasticity is the brain's ability to adapt or change in response to experiences. Every single day, each one of our brains is demonstrating neuroplasticity. We see tons of it as babies and children, but we do continue to learn and grow all of our lives. Klein and Jones outlined the 10 principles of neuroplasticity. And these principles are the foundation of all that we do in neuro rehab. So, use it or lose it means that the skills we have will remain skills so long as we practice them. One example of this for me is calculus. So, I was great at it in high school, but if you showed me an integral today, I would look at you like you're nuts because I have not used it. So, I lost it. And then use it and improve it relates to improvements in skills the more we use them. For example, when I first learned how to take blood pressure in school, I could do it, but the fact that I use this skill multiple times every single day means that I've improved in my ability to perform this skill significantly. Specificity means choosing activities which mimic the skills we want to improve. For example, to improve walking, we want to practice walking. We don't want to practice riding a bike. And repetition matters so much. The more we practice a skill through varied repetitions, the more our brain can practice sending signals through connections it's made and continue to work on strengthening new connections. Intensity matters too. Research has shown that practicing activities at high intensity promotes an environment most conducive to neuroplasticity. The phrase time matters relates to the idea that different changes may be made at different times throughout practice. And saliency in terms of neuroplasticity means that practicing activities which are meaningful and pertinent to one's life will help to produce the most gains. For example, if someone who has had a stroke needs to return to work, you can bet I'm going to find out what their day-to-day activities look like, and we'll be practicing those as part of their therapy. And age also matters. As we mentioned before, we see a better environment typically for neuroplasticity in younger brains. But that's not to say that older brains cannot make changes and adapt as well. Transference and interference refer to practicing one task in relation to another. So in some instances, practicing one task can help with carryover to another. And in other instances, it can hinder other skills. So keeping each of these principles in mind is going to help us to promote the best chances possible for the patient and for their brain to form new connections and to strengthen the ones we have in order to elicit improvements in function. I wanted to talk about two hot topics in stroke rehab. High intensity gait training is exactly as it sounds, so performing gait or walking activities at high intensity. As we just discussed, intensity is one of the principles of neuroplasticity, and by practicing walking, we're also incorporating repetition, specificity, and potentially even saliency, depending on the patient's needs and goals. High intensity means working within 70 to 85% of heart rate max, or at 14 to 17 on the Borg RPE scale of 6 to 20. And of course, don't start an exercise program until you're cleared to do so. And trained rehab professionals can monitor vitals and exercise response to ensure safety when performing activities. Using different methods such as varied resistance, overground walking, treadmill training, and stair training, we can increase intensity and target specific gait impairments, such as forward propulsion. I encourage anyone interested in this topic to look at the physical therapy guideline, clinical practice guideline for improving locomotor function following stroke, spinal cord injury, and traumatic brain injury. And then virtual reality uses technology to complete activities which may incorporate virtually all aspects of one impairments, thinking, reaction time, arm function, trunk control, leg function. The possibilities are really endless. I was at the annual seminar for the Brain Injury Alliance last week, and I went to a really great session about virtual reality. I think one of the really great things about VR is that it makes rehab fun. Having an enjoyable environment encourages practice for repetition, and focusing on activities which are important to the individual promotes saliency. In an ever-changing world, we have so many great options at our fingertips to enhance our skills as therapists, and the horizon does continue to change and adapt with continued research. So I am excited to see where we are in the rehab world and what stroke and brain injury rehab looks like in 5 years, even in 20, 30 years. Very exciting. Okay. If you take anything away from today, I want it to be this. Recovery from stroke is a journey. It's a process, and sometimes it can be really hard. Some days may be tedious, but really every step counts, literally and figuratively. We see the greatest degree of stroke recovery early after stroke. Studies vary in the exact timeline, but we do know that the greatest amount of recovery is typically seen early within the first 6 months or so. However, even after a plateau, further improvements and recovery are still possible. Improvements may take the form of small victories, but they're improvements nonetheless and steps in the right direction. Okay, this slide could morph into a presentation all on its own, and I'm probably not giving it the full attention it deserves, but we need to add social determinants of health into the conversation. So these are defined as the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. These determinants are broken into categories, as you can see in the graphic on the screen. Each of these topics can contribute to stroke risk factors, stroke recovery, and stroke outcomes, if you think back to some of the things that we've talked about today. For example, knowledge is power. Having access to resources which improve health literacy about risk factors for stroke will likely result in a greater ability to modify some of these risk factors. Economic stability or lack thereof may add stress to which we know has impacts on health. And additionally, with significant financial stress, individuals may be less likely to seek medical services, particularly preventive care. And there are countless other ways that social determinants impact our abilities to achieve health and wellness. I urge everyone who is listening today who works in the healthcare realm to think of one way that you can improve your practice by taking some of these things into account. So here's a look at the sources used for this presentation. Sorry, they're a little small on the screen. So at this time, I'd like to thank the Brain Injury Alliance of New Jersey for having me today. And if anyone has any questions, I'd love to hear them.
Thank you very much, Jennifer, for the really informative presentation and all of that great information. I'm not seeing any questions at the moment. We'll take a second and see if any questions come in. But I was wondering, and I'm not sure if I missed it or not, but I was wondering if you might be able to just share a little bit about the difference between the ischemic and the hemorrhagic types of strokes.
Sure, yeah. So ischemic strokes are typically caused by a clot in a blood vessel in the brain. And then that clot prevents blood flow, like from passing and continuing on to supply different areas of the brain. So then in that case, typically medications or even going in and removing the clot can at least help to allow blood flow to continue. Hemorrhagic stroke is typically more of when a blood vessel bursts. That can be due to a variety of different reasons, sometimes due to an aneurysm, for example, or like a arterial malformation, as another example. And then in that case, there's bleeding into the brain tissue. And then because the blood is going into the brain tissue, it can't continue on its journey to supply other areas where it's intended to go.
Okay, thank you. Do you see a difference in like who has one versus the other more frequently, or is there not, a difference in that?
I'm sure there's probably data out there about that. I'm honestly not aware of like specific breakdowns of different like risk factors and underlying conditions that could predispose someone to one type or another. But I will say that 87% of strokes, I believe, are ischemic, and about 10 to 13% are hemorrhagic.
Okay, great. Yeah, that's important. We have a couple of questions here. How to promote neuroplasticity at home after a stroke?
Yeah, the more practice, the better. That's really like the biggest thing. I would say talking to your rehab team about specific things that they would want you to practice. Um, and getting that individualized approach with your rehab team is important.
Okay, great. We have another one here asking if you could go over the exercise recommendations for prevention again.
Um, yes, from the American Heart Association, I believe. So I know the American Heart Association recommends 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous intensity exercise.
Are there specific things that fall into each of those categories?
It's more so in terms of the intensity with which you're doing things. So, kind of if you use a scale, the research shows a 6 to 20 scale as like 6 being really, really easy and 20 being really, really hard. So, you're wanting to fall around that 14 to 17 for high intensity or vigorous activity, and then around 11 to 13 for moderate intensity exercise. I believe that's the like the guidelines for the intensity ranges, but I would have to double check on those numbers.
Okay, thank you. And here someone is asking, how do you manage high expectations for your patients?
That's a good question. Um, Everyone wants to get back to where they were before the stroke, and I want that too. Um, I think being honest from the beginning and like having starting that conversation early on and saying, like, I recognize your goals, and they're my goals for you are your goals for you. And just kind of like having check-in points to see like, are we making progress? Do we see your goals and your expectations as doable, or do we need to maybe start with smaller goals and like break things down into steps? So maybe if you come in and you can't stand on your own, we're probably not going to focus on running as your first goal, but really just being able to stand independently, take some steps with help, and break it down from there. Um, I mean, hope is definitely the most important thing with a rehab journey, balanced with an awareness of reality at the same time.
Okay, thank you. We have another question here. It says, thank you for the great presentation. Someone says, I work at a community health center in New Jersey that is looking to hold programs and classes focused on stroke. What areas do you think need more awareness or see lack in access? For instance, post-care/recovery, understanding signs of stroke, etc.
I mean, I think there's definitely room for growth and awareness in all aspects. I think that as society, we're doing a pretty good job of the um, like awareness of signs of stroke and things like that. And I think we could continue to work on resources for after stroke. A lot of times after therapy is done and rehab is done, people still have needs, and I think like continuing to promote the really great community programs that we have is important.
Okay, thank you. A couple more questions here. So can you talk more on exercise prescription and the latest modalities used?
I think we covered that a little bit as far as the American Heart Association guidelines. Um, as far as specific prescription, I would consult someone on an individualized basis. Um, I can't tell everyone here to do the same exercises because that's not specific to your needs or your abilities. So I would encourage you to talk with your provider about that.
So it really would be an individualized kind of program.
Yes.
And then someone is asking, what is the initial presentation of patient? Is it flaccid initially or spastic?
That's a good question. So typically, immediately after a stroke, there is going to be flaccidity, which is like basically your muscles are very weak. And then as we progress through different stages of recovery, they're called the Brunstrom stages of recovery. You're going to see more tone come back into the muscles. Some people may have like developed spasticity, which is a velocity dependent resistance to stretch of those muscles, which can impact things like walking and daily activities. So typically, not in all cases, but typically you might see flaccidity early on and spasticity as things progress in recovery.
Okay, thank you. Looks like we have a couple more. Thank you for this. It's very informative. Any suggestions on how to create a home recovery program?
Again, I would talk to your specific therapists or other providers to find a program that works specifically for you and your needs. I don't want to sound like a broken record, but I do think that having that individualized approach is the best thing that you can do because each of us are different and have different needs and different resources and abilities to perform home programs.
Okay. Are there any things, that can be done at home, like things that, I don't know if things for recovery need sort of equipment or, materials or things like that? Are there things that are sort of simple that can be done at home that don't require anything?
I think it definitely depends. Some strokes that are more severe are going to potentially leave more impairments, and people might be pretty dependent in what they need. And other people who have had strokes might be back to work a couple weeks later. Um, so it does depend on what like equipment you might need, whether you need a different home setup, um, need more help from caregivers, or if you're looking at specific like traditional exercise.
Okay, great. And I have one last question here, it looks like, and then I think maybe there's something in the chat, but we'll take this one first. So the question is, what's the difference between neuro rehab versus regular rehab? Should stroke survivors really look for a neuro physical therapist?
That's a good question. So it depends on every like program and like the way that different therapy clinics set things up. I am biased because I am like a neuro PT, so I work primarily with people who have neurologic diagnoses. Um, and I work with a bunch of physical therapists and occupational therapists and speech therapists who all do the same thing. So we have that experience where that's what we do all day, every day. That's not to say that people who don't necessarily do this all the time can't help and do great things as well. But I would encourage if you have the ability based on transportation, resources in your community, if you could find therapists who do specialize or see this kind of thing frequently, you would be in really good hands, I would bet.
Okay. Is there different training for a neuro PT?
No, so for physical therapy specifically, I can't necessarily speak to the other disciplines. When you go to school, you kind of learn everything, ortho, neuro, pediatric, really all of it. And then after school, if you want to continue to train, you can. So I had an interest in this field and was able to find a job in a setting with really good mentorship. And then there are further programs or certifications that you can pursue, such as residencies, as well as certifications like there's a neurologic clinical specialist certification. Um, I did the certified stroke rehabilitation specialist. So that was a lot of training and exams and all of that to be able to have that designation. So it's really whatever each individual brings to the table.
Okay, great. Thank you. It looks like that's all of our questions. So thank you again, Jennifer, for sharing all of this information today and for bringing us your expertise. And one final reminder to please fill out the post-webinar survey. The link can be found in the chat. We'll keep it up for a few minutes. You will automatically receive a certificate of attendance via email once you've completed the survey. And again, just a reminder to look in your spam box because sometimes it ends up there. And again, thank you everybody for attending, for your thoughtful questions, and we hope to see you at our next webinar. This concludes today's webinar. Thank you.
Thank you so much. Have a nice day.